Everyone will be pleased to know I'm not going to do one of my technical presentations. Those that have it experienced in the past, I tend to do very technical presentations. So this is just a very broad overview of international standards that affect our work. So I'm not going to go into all the IT stuff, you'll be pleased to know. Of course, all this work comes with its own set of definitions and 3-letter acronyms and 4-letter acronyms. So I've put in the first slide some information that you can go back to and reference. I think we mostly know ICSR, but IDMP, the Identification of Medicinal Products, is something that's coming up. And there's also standard development organizations, some of which you'll probably be familiar. Most of us are familiar with ISO, even if we're not really sure what it is. When you say ISO 9000, people seem to know what that is. And if you look at your digital camera or your old normal camera, you'll have an ISO setting on there, and this is all work that's come out of ISO. So we're starting to get involved in creating ISO standards now. So my presentation will be primarily focused on the ICSR and also IDMP set of standards, but I'll briefly mention work that's starting on electronic PSURs or PBAs and electronic risk management plans, which is quite a way away, so don't panic just yet. This will come, but it's quite a way away because experience of creating the ICSR standard has shown how long it takes to develop international standards, because you need to get international agreement, not just ICH agreement. So what happened was that in the past, ICH used to write specifications. They weren't really standards. So E2B you're familiar with as being one of the main ones, along with the ECTD. These are specifications but not standards that the ICH regions agree to use. So they're not completely international. Other regions can choose to use them, other countries may wish to use them, but they come with their own flavors and additional requirements got thrown into there. So when we first implemented E2B, R2, back in 2001, as soon as we implemented it, we came across quite a few areas which could be improved in collecting information. We were lucky at that point, MEDRA arrived, so immediately implemented with MEDRA. And those of us that are old enough can remember before we had MEDRA, what a nightmare it was with comparing data across databases or systems when you didn't code using the same terminologies. The big missing point was the product information, which you heard about this morning. It's identifying what on earth the product being reported from this Japanese or US case and how it relates to European products. It's given in free text, so you have to have work processes to deal with free text information and link it through to what is that product, what is the substance, and what effect will it have on the safety of that product and the substance within Europe. So we receive about 2,000 ICSRs a day into Vigilance, and all those have to be processed and linked so that the information is publicly available in the near future. So the drug section is one of the hardest ones that we've had to cope with over the last 10 years that Vigilance has been accepting data. So along with the experience of E2B, we went back to ICH and started the work of looking at improving it based on experience and in changes to the way legislation had changed in the regions and how pharmacovigilance science had evolved. So that started back in 2005. So we started the work, went back, wrote a step 3 document, and then everything changed in ICH. Mainly because of the US, and I'll come on to that in a minute. ICH was no longer allowed as a group to create its own technical specifications. We had to go out and develop them with standard development organizations to make them truly international standards. There was a sort of spiel to say that it allows interoperability, robustness, and you can use resources from the outside community, but it then ended up being all of us that in ICH going to all these meetings and developing it ourselves. So resource saving wasn't actually an outcome of it. But so I said the FDA were the main drivers of this new approach is because they had a mandate. They have to follow healthcare standards that are used in the US. And at that stage, it sort of changed the way ICH thought about developing standards. So this driver forced us to go back and look at how we could implement international standards that are interoperable with the US implementations, and also with the caveat that the EU has to implement CEN or ISO standards. So that threw another problem to taking this work forward. So we did a lot of head scratching in ICH to how to address this sort of opposing way forward to develop international standards. So we were lucky just at this stage, ISO, CEN and HL7 came together to form a consortium to develop standards together, because the SDOs were developing standards separately for the same subjects. So they were conflicting international standards. And someone pointed out that I love standards. There's so many to choose from. So this was recognized by the SDOs themselves. So we were quite lucky at this stage that this consortium of international standard development organizations came together. So you have ISO TC215, which is the group working on pharmacy and healthcare, CEN TC251, which is a mirror group of the ISO group, just numbers around the other way. And you also have HL7, which is originally was a US group, but it's now truly international because the NHS in the UK uses it, Netherlands and many other countries in Europe are now using HL7 standards for their own healthcare provision systems. So electronic health records, pharmacy communications, prescriptions, etc., all run through HL7 messaging. We also had, at that time, other newcomers to the group, so CDISC, who developed clinical trial-related set of standards, and GS1, which you're probably familiar with, barcodes and supply chain, also got involved. So we had this huge collaboration of groups working together, with ICH acting as a liaison to drive its requirements through. So we were quite fortunate that ICH came along at this point. It delayed the development of E2B, of course, because we had to work out how on earth to change this way of working to create international standards. So the agreement was that we went through HL7 and ISO as a joint ISO HL7 standard that would suit both European and US requirements that were put on to us by legislation. So working in this forum, we went with our central set of ICH requirements to create a message in an ISO standard. However, there were some aspects of the ICH requirements that couldn't be agreed because they are felt outside of ICH's set of agreements. So in the US, you have VAERS, vaccine reporting. In Europe, you have advanced therapies. These are things that ICH aren't really dealing with. So they became regional requirements that were put on top of ICH's requirements. But the ISO standard was fine because it could be worked with all international additional requirements and make sure that they were all interoperable with each other. So what you'll find is that the ISO standard is much broader than the ICH specifications, and there'll be some additions to cover the regional requirements. You mentioned Japan. Japan has additional requirements for the J file, which is a set of administrative information that goes along with the E2B message. So that's all incorporated into the new standard. I said I wouldn't show you anything technical, but yeah, this is what we had to, we were thrown into this, and I spent a long time trying to understand HL7, and fortunately now I do. But the good news is you don't. Because ICH is developing and has released for ballot an implementation guide that takes out most of the technical stuff and really leaves it at a stage that you can implement the standard without actually understanding the information data models, which is what it's built up through discussions in HL7. So this kind of thing you'll see in the standard if you went out and spent 200 Swiss francs buying yourself a copy. But there's no need to buy a copy of the standard. You can implement without it. So after almost 6 years of work, we ended up with the ISO standard 27953. I know it off by heart. I've seen it for long enough that yeah, it's burned into my retinas. So it's now an official ISO standard and is out there for implementation. There's still some work to do. In May, there's a meeting of ICH, and there they're hoping to collate or go through all the comments that have been raised against the public consultation, which ended in March. So we've received all the EU comments. Thank you to those that have submitted them. It was mostly through industry associations, but a few individuals also posted some comments. So we've gone through those, and those will be taken to ICH in the May meeting for discussion and perhaps revision. And some people have gone with a fine-tooth comb. Really, they've spotted things that even the Japanese missed, and that's saying at the level of detail, because the Japanese are the main drivers of the E2B document, and they're very precise and make sure that everything's correct. But as always, someone spots something. If you've been looking at the same document for 5 years, you tend to not see things anymore. Okay. So we are hoping that step 4 should be reached at the end of this year. So the November meeting, they should sign off at step 4, which means it's ready for regional implementation. So I mentioned that there's some regional things that were outside of scope of ICH. So we need to provide a EU implementation guide that adds on those additional specific points that were not covered by ICH. And the idea is that the ICH regions still work together to make sure that it's completely interoperable, but our additional legal requirements are covered by the standard. So you'll find some additional advice on advanced therapies, medicinal product defects, falsification of medicines, medication errors, abuse, misuse, etc. Will be additional guidance will provide for the EU implementation guide of the ICH implementation guide. The FDA will also have similar implementation guides which add on their additional requirements for, say, vaccine reporting and other areas where they'll be using the standard. And it's intended, and I should say ICH Step 4 document, not Step 3 at the bottom of the slide, that we'll release it roughly at the same time as the ICH one is released. Okay, so I mentioned before the problems we had with E2BR2 in terms of identifying the medicinal product information in the reports. So a big project was started through ISO to detail the identification of medicinal products. It was originally it was just one standard that was put forward. That soon got split into separate set of standards. So now you have a group of standards. Originally it was 5. I think it's been reduced. Yeah, it's still 5. It was originally 6. It was reduced to 5 because there was one on lab tests, but that's been dropped at the moment. So for the identification of medicinal products, you have the medicinal product information as being one of them. This is really going down to the box that's on the shelf of the pharmacy. So this contains the information to highlight down to the packaging level. Then you have another one, which is the pharmaceutical product. And this helps you identify products that have the same active ingredients or combination of active ingredients, the strength, pharmaceutical form, and different levels of hierarchy that will identify boxes on the shelf of the pharmacy that are the same or similar. So it's kind of a way of grouping the information in a useful way. You also have to have an international list of substances or a coding system so that you can identify that the product in the US is the same as that in Europe. It may have a different trade name, trademark, etc., but it contains the same substance. So you need to agree internationally on how to name these things and make sure that they're consistently reported. Also to deal with the fact that there's synonyms and linguistic differences and also translations. Particularly in Europe, we have the issue of translations, so that's all covered by that. Then you also have supporting controlled vocabularies that need to be agreed. There's a lot of work went on between the European Pharmacopoeia and the US Pharmacopoeia in going through the information regarding dosage forms, presentation, units of presentation, routes of administration, and packaging. because we do things differently. So we have to know whether what we call something is the same as what they call something. So there's a lot of work to go through understanding if something's unique or whether it's the same and it's just a synonym to mean the same thing. So a lot of work has gone on into describing how we collect this information. But the standard itself is just a set of data fields that would allow this work to continue. It's not the actual set of controlled vocabularies. Those come after. I say that with the exception of the identification and exchange of units of measurements, because there's already standards widely used by healthcare industry and also outside of healthcare, and that's UCOM set of units. So where are we at the moment? Well, when I wrote the presentation, the ISO final draft international standard was open, but then I thought actually it's actually closed now, because by the time I gave today's date, the ballot has already closed. So hopefully all the comments have been submitted and those are being gone through at the moment. There should be only editorial changes to the document. And the idea is that there'll be publication of the ISO standards or set of standards by the end of this year. So the IDMP set of work should be done in terms of ISO. But that doesn't mean we're finished. There's still an open area of actually collecting the data now. We've got the structures to represent the information, but not the data itself. So we've got the containers, but not the actual data. So there needs to be some way of working between industry and regulators for this information exchange to take place. So there's a messaging specification standard developed by HL7, or is in the process of being developed by HL7, that will allow the communication in accordance with the ISO standard. So that sets up the messaging exchange of information. And then, of course, there's the harmonizing the information between regulators and publication of the data, of course, that needs to be worked through. So where are we with this messaging format for the content? In HL7, there's currently a ballot open for the messaging format, and that's scheduled to be completed by May, this balloting period. Then ICH has to do some work in the M5 group to work towards creating some sort of agreement for the maintenance of the content. And in the May meeting, they'll hope to push this along and ready for step 2 sign-off in November. But we're still waiting a bit for the HL7 work to be completed. And from November, there'll be a step 3 consultation, so you have the chance to comment on it and work towards a step 4 document, which is basically the final document in November 2013. Excuse me. So ICH will create the implementation guide for these MPID, PHPID, substance ID, dose forms, etc. units of measurement, and it will cover and explain how those all interrelate and how that information should be structured within an HL7 message for communication between all parties concerned. But there's the big open areas, the terminology maintenance, and how the process will actually work to maintain those terminologies, and who maintains them as well, is all part of the discussions that are ongoing. So ICSR itself will be a consumer of this information. So E2BR3 messages can contain the IDMP information. So there's a lot of information that comes out of this set of standards that can be incorporated within ICSR. And we would have our equivalent of the measure terminology for IDMP information, essentially. So we move forward and we're able to work with this data very, very easily. Okay. I should say that the new ICSR standard can be used without IDMP, which is important because you may not always have an IDMP code for quite some time until the entire world has an IDMP code for all products authorized everywhere. So we have to be able to cope without IDMP information until then. But if there is an IDMP code, then we should use it because it helps really clearly define what the information is. And again, you can use different levels of the hierarchy of information to represent the information available. Okay, thank you very much. Sorry, I was thanking my colleague for bringing me water. You're not over yet. Oh dear, that's better. I've still got a bit of a cold, and it's my throat is really tickling. I want to cough, but I don't want to deafen everyone on the webinar. Okay, so that's the end of the IDMP and ICSR. There are two other projects of interest. I mentioned ePSUR and risk management plans. So these are just really starting up, and what we're doing at the moment is working with the European PSUR assessors, because you can imagine their task that they're going to be faced with change to the PSUR assessment. When the URD date comes up and suddenly you get a pile of PSURs appearing on your desk as a PSUR assessor, you may have 15 or more PSURs for the same substance. Suddenly you have to provide one assessment report and read through all of those documents and provide a consistent report. And how you do that with PDF documents, I take my hat off to them, because that's going to be quite a page-turning exercise. So to improve this work, we're working with the PSUR assessors and finding out what would make their life easier. So for instance, if you just say within the, these are the issues that came up within the period of this PSUR, hepatic failure, renal failure is reported by marketing authorization holder 1. Marketing authorization holder 2 also talks about hepatic failure, but they also talk about QT prolongation. So they can immediately build up a list and find the discussion and see what the issues are. So, okay, I've been told to get along. So this is just starting, and hopefully by January 2013, we should have a draft available. So thank you.